Okay, good afternoon, good morning, everyone. This is Lisa Dulski-Watkins with the Milbank Memorial Fund Multi-State Collaborative. Welcome to our May 2019 monthly topical webinar. Today we are delighted to have with us some wonderful staff from both CMS and from Deloitte. We are going to be seeing a demonstration of the CPC Plus Data Feedback Tool, the DFT as it's called, the data platform that was created for practices participating in the CPC Plus. It enables them to view their performance data and includes dynamic functionality for practices to analyze their data, develop insights, and plan improvement activities. The tool displays performance compared to practices within and across regions, and also has drill down information to provide details on the performance factors that drive variation for the practices. This demonstration is a great opportunity for those of you on the phone who want to understand the kind of data and analytic capabilities that CPC Plus practices receive from CMS. And as of course, this is obviously a tool that when used by the practices has specific information that is personal information, and we certainly are not going to be sharing that today. So this is de-identified or even dummy data. I'm actually not sure exactly. I'd like to take this opportunity to introduce both Emily Johnson, who is the Payer Engagement Lead for CMMI and for the CPC Plus in particular, and she has helped coordinate this event. And our presenter today is Anita Desai, who is an RN by background and is the Deloitte Direct Feedback Tool project director, has been working on this for 2 years. Her previous experiences was at Johns Hopkins University in quality and analytics, and so she really has deep personal experience as an end user and some sense of what payer feedback feels like and the way things can be used and improved upon. So with that, I'd like to just remind you once again to please mute your phone or your computer audio. I can do that centrally, but I'm trying not to because I want to leave the opportunity for people to ask questions. So just please remember to do that. You also have the opportunity to look at the chat function on this, and we will monitor that so we can see if there are questions that we can hold off till the end of the presentation. So with that, I'd like to turn it over to Anita.
Thanks, Lisa. Hi, everybody. Thank you again for having us today. We're very excited to share our CPC Plus Data Feedback Tool with you today. We are going to try to take about 20 to 25 minutes for the actual demo. Feel free to ask questions during the demo, or we're going to reserve a lot of time towards the end of the session to take any additional questions and have some further discussion around this. So is everyone able to see my screen? Can somebody just confirm for me?
Yep, we can see it. Thank you.
Wonderful. Thank you so much. So what you see here is the CPC Plus Data Feedback Tool. This was deployed last year to all CPC Plus practices. And this was preceded by an Excel version of a data feedback report that the CPC Plus practices used to receive. So this is really a lot more dynamic functionality than Excel was able to provide, and practices have really responded very well to it. We engaged practices actually from very early on in the development process. Just when we were starting to design wireframes, we had focus groups with about 18 CPC Plus practices, as well as a handful of practice facilitators to really obtain feedback on how to make this tool most useful and usable for the practices. And we were really able to incorporate a lot of that feedback, which we think is a large contributor to why we have pretty good adoption rates with the tool thus far. And we do continue to obtain feedback from the practices. At the CPC Plus National Meeting last week, we had a booth where we were sharing the tool with practices for additional feedback, and we're continuing to take that feedback and build out enhancements to the tool. So this is built out in MicroStrategy, and it is available through the CPC Plus portal. What the practices see here, this is the home page, which is really just a snapshot of their performance. And then there are subsequent tabs at the top where the practices can drill down on different domain areas. They can see here their key performance indicators for CPC Plus, so inpatient hospital utilization, ED utilization, total Medicare fee-for-service expenditures, ambulatory care sensitive discharges, and 30-day readmissions. And we've color-coded it according to their performance from the previous quarter so they can see how they are progressing over time. And they can also choose who to compare themselves against. So just as a general benchmark, they can compare themselves against their region average, or using this filter here, they could select to compare themselves against all regions. And that will dynamically update the comparators that are in all of the graphs and visualizations on the page. And is loading at the moment, so I'll just wait for that to continue. So as you can see here, all of the lines and the graphs got updated, as well as this data point here. Some of the other ways that we can filter the pages on the tool are by risk tier. So if a practice wants to only focus on one of their higher risk tiers, such as 4, they can do that, and that will narrow down all of the data according to that risk tier. They can also drill down by specific chronic conditions. So if, for example, a care manager is using this tool and they want to focus on the high-risk diabetic population, they can use the chronic condition filter to look at the diabetic patients. And then the last filter that we have here is data through. So it allows the practice to look at previous quarters' report. So right now you can see the most recent is 2018 Q4, but if they want to look and compare themselves against how they were doing the previous quarter, they can use that filter there. This ribbon here is really just a snapshot of the total practitioners, attributed beneficiaries, and the average HCC risk score for the practice. And then going down, they can look at trends over time for each of the KPIs. So they can use the drop down to select any KPI that they want to focus on. And then they can see how their practice is performing compared to their region or all regions, just to answer some of the basic questions of, you know, is my readmission rate increasing or decreasing over time? Is it higher or lower than my peers? And then there is functionality on each of these graphs where they can adjust the time sliders. So if, for example, the practice implemented a performance improvement project during this quarter and they don't necessarily want to look at the previous quarters, they can use the time slider here to adjust which data points they're looking at. And the graph at the bottom right is measure relationships. So it allows the practices to look at acute inpatient discharges. So basically the utilization versus the expenditure. And they can do the same thing for ED visits as well. So this allows the practice to see where they fall in the context of all of their peers. So I, as a practice, I am the blue dot. So I'm pretty much right in the middle of where all of my peers fall in terms of utilization and expenditures. But what I could do is actually toggle over time. So I can look at the previous quarters to see really where my dot moves in the context of all of my peers. So as you can see in the previous quarter, there was a lot more spread in terms of the total discharges. And by 2018 Q4, that spread lessened a little bit, but it looks like my overall dot has not changed significantly. So once practices take a look here at their overall snapshot, they can determine where they really want to focus their efforts, and they can use the subsequent tabs to drill down on that. So in this case, as a practice, I might really want to look at my ambulatory care sensitive discharges and my overall admissions. So if we toggle over to the utilization tab, here, what the practices are able to see is all of the various utilization measures. So this is a lot more than just the snapshot that they saw on the home page. They can see the same measures, but then they can also see observation stays, ED visits leading to hospitalizations, and all of those ambulatory care sensitive discharges broken out individually. At the bottom, they can see just a snapshot in time, so how they're performing in the current quarter for that given measure, the previous quarter, as well as the percent change, and then a trend graph below on how they're really performing over time. At the top, what they're able to see here is top diagnoses and facilities. So this is something that we're continuing to build out for additional measures. Later this year, we'll have this functionality available for ED visits and acute inpatient hospitalizations. But what this allows the practices to really see is, why are my patients going to the ED? So what are the top 2 or 3 or 10 diagnoses that are driving my patients to the ED most frequently? And they can click on any of those diagnoses to see the full description there and how many visits were associated with my beneficiaries for that diagnosis in the given quarter. So this would really allow a practice, if the first diagnosis here is asthma, then, maybe we really need to look at our care protocols around asthma and how we are managing that and how we're making sure that practices are getting seen on the same day so they don't end up in the ER. Another thing that they can see here is the top facilities. So which EDs or which hospitals are my patients going to most frequently? So I, as a practice, could take those top two or three facilities and work very closely with them in terms of coordination, alerting us as the PCP when our patients are admitted or discharged, sharing medical records, any other good care coordination efforts to help lower unnecessary costs and improve the quality of care that the patients are getting. Then we can toggle over to beneficiaries driving utilization, and this will be a scatter plot of all of my beneficiaries by risk score and number of visits. So the number of visits will correspond to whichever measure we select here. So this could be ED visits, it could be overall hospitalizations. And this visualization really allows you to see who are your outliers, who are your frequent flyers, and you can hover over any one of those dots to see who the patient is and the total number of events that they've experienced. As you see here, this is just dummy data, but it would be reflective of your actual patient identifiers. And we've built in this functionality to quickly turn this graph into a table. So we heard a lot of feedback from practices that they need to get their lists of high utilizers and they want to be able to export those lists. They don't necessarily want to log into the portal every day. So this allows them to come over here, turn this into a graph, and then they can actually export any of these tables over to Excel or PDF. And this functionality is actually available for all of the graphs and visualizations. So this, for example, we can turn it into a table view so that the practices can see their specific data points without actually having to go over each point and take note of those. The next page that I want to show you is expenditure. This is very similar to utilization in terms of the layout and functionality. However, the primary difference is that you're focusing on your expenditure measures. So these are broken down into inpatient, professional outpatient, numerous outpatient categories, and then my practice primary care and all other primary care. Here we can see below a snapshot as well as a trend graph. And then here we can see how the expenditures have actually trended quarter to quarter. Similar to the utilization page, you can see the beneficiaries who are driving the expenditure. So whereas utilization answered the question of who are my high utilizers, this really answers the question of who are my high cost bennies by category. So who are the ones driving the most inpatient costs, who are the ones driving the most outpatient costs, who are the ones being seen most by primary care outside of my practice. You know, that might be a particular category that I want to hone in on and make sure that we're providing the best care to that patient. If we toggle over to the specialty page, a lot of practices have told us that they find the specialty page to actually be the most useful for them because it allows them to look at this historic data and make decisions today about potentially shifting referrals to other lower cost specialists. So on the left side, a practice can see who are my top specialties by expenditure, and this is looking at a per beneficiary per month amount. So ophthalmology, cardiology, and diagnostic radiology. And then if you come over to the right side, you can select one of those categories and actually drill down on those costs a little bit further. So this allows you to see how has my cardiology expenditure trended over time and how does that compare to my peers. So again, we can use the same comparators of my region or all region to allow them to see if they are, you know, an outlier or if cardiology spend over time has truly been increasing across the board. And then one of the most actionable pieces on this page is that it allows them to compare their top specialists for cardiology. So they can see their top 10 specialists, the NPI, total beneficiaries seeing that specialist and the total visits they had. average expenditure per visit as well as the total expenditure. So the expenditure per visit really helps them compare apples to apples between the specialists, whereas the total expenditure gives them a view of, you know, the overall picture. And what the practices can then do is see a little bit more granular information on each of these specialists. So there's a subsequent specialist drill down page. Here they can select that specialist that they want to focus in on. They can see how the expenditures, patients, and visits have actually been trending over time. They can see the top diagnoses codes that that specialist is billing for their beneficiaries. So the majority of my patients are seeing this specialist for heart failure, AFib, and cardiomyopathy. And then they can get a list of exactly which patients are seeing this specialist. And again, if they want to export this table and share that with each of their PCPs or share that with their case manager, they're able to do that as well. One of the enhancements that we have slated for the report is actually on the specialty page as well. So as I mentioned, the practices really do find this very actionable, but several of the practices said, you know, it's great to know the diagnoses associated with a particular specialist, but what they really want to be able to do is compare different specialists, apples to apples, on how they treat the same condition. So we are planning on basically building in an additional filter layer here. So select a specialty, which is cardiology. Then they can see their top diagnoses for cardiology, and they could actually select one. So here they could say cardiology and AFib. And then the top specialist table will be adjusted based on the cost for that specialty and diagnosis combination. So I'm now comparing specialist A and B apples to apples on how they treat AFib. Care delivery is another page in this tool. This is data that the practices self-report. So this is really the only data in the tool currently that is not based on claims. So these are things that the practices report, and we're basically just presenting that information back to them, allowing them to see their trends over time, as well as allowing them to see how they compare with their peers. Loading the demographics page. So demographics page is fairly straightforward here, but allows the practices to see how many beneficiaries fall within certain risk tiers, how many of their beneficiaries are dual eligible, or to see breakdowns by age, gender, or ethnicity. And then for each of the pages, we have these question marks that allow practices to see a little bit more detailed information, whether it's about how to interpret a graph or how to interpret a measure. So a very abbreviated version of a measure specification, for example, such as ED visits, we're looking back 12 months, includes or excludes planned hospitalizations or planned readmissions. But then we do have a quick tips tab here that allows them to see some more detail and definitions for each page. So this allows them to see really, you know, the full definition of chronic conditions, a much more comprehensive version of measure specifications. You can see here, ED visits are based off of, I apologize, my clicking is getting everywhere here. But they can see, for example, that ED visits are based off of the HEDIS specifications, and they can actually Control F on this page and search for example readmissions, and it'll take them to that portion of the page so that they can focus in on what they need. There is also a sort of a self-service tool that allows practices to go and create their own beneficiary reports. So if they want to look at a certain quarter, they want to pull in patients who are dual eligible or above or below a certain age, who have a certain chronic condition. they can select from these different criteria. They can say, for that denominator of patients that I selected, I want to see their inpatient expenditures as well as their inpatient utilization. And this would allow them to basically create and save their own beneficiary level reports that they can access in the future. So I'm going to pause there. That kind of completes the demo, but I'm happy to take any questions.
Anita, thank you so much. Everybody is potentially unmuted if you would like to ask questions, and also feel free to type information into the chat function, and I'll be happy to read your questions for you.
Hi, Anita. It's Pano Yarkaris from Rhode Island CTC. This is just tremendous. I've seen a demo before, but it seems like it's continues to be enhanced. I do have one question. I think the specialist comparison is great. Are you thinking about, or how would is there a way to create a kind of a risk adjustment when you're starting to look at specialists and how they handle same conditions, so that that would be one potential?
So that's a great question. Currently, we don't have the risk adjustment functionality on the cardiology page, and that actually reminds me that we do have that available on the homepage, so I can show that in a minute. But in the specialty redesign, I believe we are starting to at least pull in the average HCC risk score associated with that specialist. So although it's not performing the risk adjustment, it's allowing them to see the difference in acuity between the specialists for the patients that they are seeing.
Right.
And I believe
are there any
specialists? Oh, go ahead. I'm sorry.
No, that's fine.
So here on the specialist drill down page, they are able to see at least the risk score and risk tier per Benny. But that's great feedback.
So a question.
I'll just take this.
I'm sorry, did you want to add to that, Anita?
Oh, I was just going to say, he reminded me about risk adjustment, so I was very quickly going to just toggle over and show the risk adjustment functionality on the home page.
Yeah,
so this was actually drawn out of specific practice feedback as well. So there were a few practices that said, we have much sicker patients than other practices, so a lot of these visualizations are not meaningful to us unless the home page is risk adjusted. So what we added here, just in this current report release, is a risk-adjusted option. So the default is set to no, but if they select yes here, it will actually risk adjust all of these graphics. So I think this scatter plot is the one that, there was one particular practice I'll never forget who said, a lot of our practitioners or a lot of our patients are nephrology, so we just have a lot sicker patient population, so it's not fair to show our blue dot all the way up here. You really need to risk adjust it. So that's what this functionality allows.
Great, thank you. We have a couple questions that have come in on the chat function. The first one is if you're able to track the level of use by the practices. So specifically, how often are the clinical practices manipulating their data to drive practice and outreach opportunities, if you have some sense of that?
Sure. The answer is yes. We do track usage, and we, we share that back with CMS every week. So we can look at the logins since the tool was actually deployed, and we can also look at the logins for this particular report release. So we refresh the report quarterly. So we try to look at both the unique number of practices who have ever logged into the tool, and then the unique number of practices who have logged in since the report was most recently released. Jeff or Monica, I'm not sure if either of you are on the line. I believe our current adoption rate is around 70%. Yeah, I apologize. I'm not sure if they're on the line, but the current adoption rate, it is around 70%.
Great, that's very helpful. Thank you. So another question was came in from Karen Johnson in Kansas City, asking if this tool is used to aggregate data across payers for the regions that already have a data aggregator in place.
So no, this is only the Medicare fee-for-service data. So CMS does participate in CPC Plus data aggregation in select regions, whereby it provides the Medicare fee-for-service data to the data aggregator to incorporate into their tools. But this specific data feedback tool is only the Medicare fee-for-service data.
Okay, thank you. And then another question came in about the lag time for the data. Obviously, we're seeing dummy data here, but how recent is the latest data if a practice were to just log on today?
Sure. So it is, I believe, what we're looking at here, the most recent quarter is 2018 Q4. So it's about a 6-month lag. I think we allow about a 3 or 4 month run out, and then allow another month or 2 for the actual processing of the data.
Great, thank you.
And Anita, I can speak to that. Sorry, it's a 2-month claim run out, and then approximately about 2.5 months of processing and uploading and updating the tool.
Great, thank you. Another question came in specifically about the specialty provider data. And the question is whether that takes into account the severity of the illness per episode in addition to the risk of the member.
The severity of the illness, could the requester just expand on that a little bit more? I'm assuming you're talking about more than just diagnosis.
Yeah, it's Diane Parrish. Can you hear me?
Yeah, hi,
Yeah.
Diane.
Hi. So what I'm talking about is sometimes the risk score of the patient may be low, but they may have an acute event uncharacteristic of their risk score. So looking at the severity of the level of the illness might be, for example, high expenditure for that particular person, but their risk score may not reflect that over time. So do you take into account for the specialist the severity of the illness burden at the time of the acute event? Because we do get that pushback from our provider community.
Yeah, no, that's a great point, but no, we don't. As I said, we are working to build in the diagnosis filter to allow them to look at specialists based on how they treat a certain diagnosis, but we are not currently taking severity of illness into consideration.
Okay, thank you.
Are there other questions or comments? So this is Lisa. I actually have a question in terms of, I'm sorry, go ahead. Does someone else have a comment or question?
Yeah, sorry, it was Pano again. So I'm just trying to think about, and maybe you can't answer this, but how CMS is thinking about this tool. It's such a powerful tool at the practice level, but there's also potential usage if you started to think about ability to aggregate across practices. I don't know if, for example, if you have a system of care that might have 20 practices in CPC Plus, can they look at them together some way? I guess you can I guess as I'm talking about it, you can export it to a Excel and then kind of combine things if that's available, so that you're not. I know CPC Plus is aimed at the practice level, but I could imagine systems of care wanting to use this for their advantage. Is that how they would begin to look at that if they wanted to try to aggregate, particularly the specialist activity, and look at it on a larger scale to avoid some of that small number issue?
Yeah, sure. Great question. We definitely hear that from practices, that they would like to see a system level view. So it's a potential enhancement that we are considering for the future. But there's a lot of them who said that, we have 39 practices participating in CPC Plus, so it's just not a good use of our time to go through and basically pull this report 39 times export all of the data, and then they're kind of forced to create their own reports or tables or visualizations to understand who are their high performers, who are their low performers. So it's functionality not currently available, but it's definitely something that we are considering for the future.
And then the other is an even wilder thought, which is, we've struggled so much, so I know years ago we didn't go down the EHR route of having a single EHR or anything like that, but I don't know if they're, maybe it's a prompt for thinking in the future, but, communities and states or folks that could, if CMS is even ever thinking about maybe after CPC Plus evaluation, having this available, where you even buy into it, where you could imagine you could put multiple different claims from multiple different sources, different health plans and other things like that into this tool, and you could have a much wider view of your practice or your organization. So maybe it's, you can't answer that yet, but I'd hope that they'd be thinking about something like that.
Emily, do you have any response to that one?
Yeah, I would just say, I think it's hard not to look at this and have your mind go there. I think if that were an enhancement that we were going to think about, it would be a longer term process, but I think it's definitely an interesting idea and something that is worth considering further on our end.
Oh, that would be fantastic. Thank you. Thanks.
Other questions or comments? So I have a couple of questions that I think I hope it would be helpful. Obviously, this is an exquisite tool and just provides an incredibly powerful set of views and the ability to drill down to very specific information about individual patients. And you mentioned that there's about a 70% uptake in terms of the practices that are using it. What kind of supports are in place, if any, to help practices become acquainted with the tool and to use it comfortably?
Sure. So as we deployed the tool last year, we did develop a handful of user materials. There were 6 webinars that we developed and posted onto CPC Plus Connect that showed the practices how to navigate the tool, how to use the different functionality, how to understand the data. And then we have also created a user guide and a quick start guide and a couple other reference materials for the practices. And practices do have practice facilitators available to them who go out to the practices and provide some coaching and support on a one-to-one basis when they're out there. So I think that's really the direct interaction with the practices. We don't have as much of that direct interaction. It's mostly the regional learning, who is out there working with the practices on how to use the data for improvement.
Okay, so it's the regional learning network staff that's going out and to help the practices learn how to use the tool. And you also mentioned that you were definitely making some modifications over the last year or so in response to practice feedback. I wondered what the mechanism was for that and how that communication is happening.
Sure. So there's a lot of ways that we hear feedback from practices. Some of them were things that we heard prior to even releasing the tool or during the soft launch or go live that we've, continued to collate that feedback and continue to prioritize which enhancements we are going to implement sooner than later. We do get some requests or recommendations through the help desk that we kind of add to that list of wants from the practices. We do hear from the regional learning contractor as well. So when they're out working with the practices, they do come back to us sometimes and relay any recommendations or questions that the practices have had. And then at the CPC Plus national meeting a few weeks ago, we interacted with practices through the booth as well as through some of the other sessions where we heard from practices some of the feedback of things that they wanted to make the tool most useful moving forward. So those are some of the ways that we get the feedback, and what we do is really continue to keep that enhancement list up to date, and we continue to review that with CMS and determine based on impacts to practices as well as level of effort, we're able to prioritize which enhancements we want to implement for each release. We also want to be conscious of not making too many changes at a time. So what we try to do is group more of the enhancements into every other release, so that it's not like every quarter the practices are trying to figure out how to use the tool differently. So we want to minimize some of that practice burden, but make sure that we are addressing their needs and their feedback on the tool.
Thank you. There's another question that just came in, just out of curiosity. What is under the care delivery tab?
Sure. So care delivery are measures for CPC Plus that the practices self-report. So they basically tell CMS what % of our active patients are impaneled, how many of our ED discharges did we follow up with, how many of our patients are risk stratified under care management, hospital discharges that we followed up on, and the average number of patient family advisory council meetings. So it's a pretty straightforward page where we're basically taking all the information that they've submitted to us and giving it back to them in a visual format so they can understand how they're trending over time and how they compare to their peers.
Thank you. Other questions or comments before I ask my next question? This is great, private audience. So obviously we're in a new phase with primary care first having been announced and slated to launch in the beginning of 2020. Is this tool going to be available to the primary care first practices that are not currently CPC?
Anita, do you want me to take that one?
Yeah, sure.
Thank you.
Yeah. So the answer is yes. We're planning to offer this to primary care first practices as well.
Great. Our understanding is that they won't have as robust access to practice facilitation because of the type of practices you're expecting to be part of the new primary care first, but I'm assuming there still will be support for the practices as they enter into this.
Yeah, that's a good question. I think, we will be doing onboarding for practices and continuing learning and education opportunities at a national level. And so I think those will all be great opportunities for kind of introducing the tool and providing support for practices and getting used to using it.
That's great. I mean, it's clearly just such an incredible opportunity for practices to understand what their hard work is resulting in. And looking at their patients. Other questions or comments? This has really just been a tremendous opportunity, and I really appreciate the care with which you've both designed and implemented this tool, and your willingness to share it with those on the phone who wouldn't otherwise have direct access to looking at this.
Sure. This is Anita. I would just be curious to hear from other folks, what experience they've had with similar data feedback tools and really helping to drive the adoption of those. While we're happy with 70%, we are continuing to strive to increase that number. So would love to hear from others how they've been successful with improving adoption.
I'm not sure I can answer that, Anita. It's Pano, but at least one question I was going to just ask was have you, has there been any outreach through the, through the practice facilitators or anything for those practices that haven't used the tool? Because that might be one step, is just using them.
Mm-hmm. Yep, that's a good idea. I am not sure. We do share the usage statistics and the practices who are not logging in with the practice facilitators, but I'm not sure if they've necessarily gone to practices and have had that conversation. But that's a great point.
So this is Dick Schonk in Cincinnati. Can you hear me?
Yes.
Yep, I can hear you.
Hey, Doc.
So one, the tool is great, and we've had a little bit of an advanced preview of the improvements because we also do the learning and diffusion work. So I kind of can speak from both sides of the aisle, and I think, Anita, to your point, we're running into the same concerns about or about practices engaging in the tool that we produce that includes CMS data. But we also, in our learning sessions, as you well know, take this data out to the practices through our practice facilitators. And it's interesting to see their reaction to all of that. I think you're wise in keeping your updates to a minimum. The one thing that we found, the practices get overwhelmed rather quickly with too much data. And our mistake was to go out with 40 different dashboards and realize that maybe they didn't have use for 40 different dashboards, and to our shock and dismay. But we needed to, but I think that what we are trying to do is, through our practice facilitators, try to tailor the reports so that, and this is something I have an active interest in and haven't done it yet, but I think that if I could figure a way so that when the practices get on the tool, that they would actually, that what would show up on their screen first thing would be the dashboard they wanted to see. So if they're working on ED utilization, the ED utilization is the first thing to show up, type of thing. So that's kind of the area that we're working on to help engage practices more.
Helpful, thanks.
Hi, Anita. This is Eric Muther from the Greater Philadelphia region. In answer to your question, we too have had challenges in getting folks to use our platform and interface, which has data aggregated from our 2 commercial payers and now fee-for-service data from Medicare. We've found, at least anecdotally, that because we have a high number of practices that are a part of a system, to I believe Pano's earlier question, that many of them have either administrators or others who need to look or would prefer to look at the data from a system level and look at multiple practices either all at once, not necessarily to compare them to each other, but because they're responsible for reviewing multiple practices for the system. And as a result, because we don't do that in the exact way that they want, and many of those systems have their own sophisticated information management systems and various platforms, including ones that integrate directly with their EMR. Between the delayed time frame for the claims data, but then also the somewhat incomplete picture compared to theirs, it makes it a hard it gives us a hard time to make a compelling reason why it's worth their logging on and looking at it. So I do think going forward down the line, if there was an opportunity to connect practices and view them at a system level, I think that would help increase adoption. But I think, we all will face a similar challenge since many of these practices are somewhere between moderately sophisticated to fairly sophisticated, and probably went into this with some idea of how they would manage their own data and maybe using their own system. So I think the key will just be to broadcast, communicate, and advertise the functionality, because I do feel, having seen several of these systems myself, I can say, in my opinion, I think the platform you have is best in class, among the best, if not one of the best I've ever seen. So I think if some of these practices had an opportunity to actually see it, and I know many of them have seen it at regional events, but perhaps again, it might change their mind.
Thanks, that's very helpful.
Emily,
Yeah,
this is Diane.
Oh, sorry.
Sorry, go ahead.
Go ahead. Oh, I was
This
just
is Diane
going to say,
Perry.
Eric, I don't.
Go on.
Go ahead.
No, that's fine.
Mm-hmm. Okay, so Eric, I was just going to say, I'm not sure if you were able to attend the CPC Plus meeting a few weeks ago, but we had a breakout session on data aggregation and really heard from the practices, certainly not limited to data aggregation in the scope that we were discussing, but the practices really just said, you know, we're overwhelmed. There's too many different platforms, too many different formats. You know, all the payers have multiple reports for the different programs that we're participating in, and then we have multiple payers. So it's just, you know, overwhelming and requires a lot of time and resources to invest. So I think that certainly helps explain the inability to get to 100% across all of the tools, but, you know, I appreciate your feedback. Go ahead, Diane.
Okay. So you were speaking exactly to partially what my point was going to be about the multiple tools and multiple payers, and we experienced that in our region as, you know, we're pretty much value-based in the whole region, and everybody has their own tool. So that could be some of your 70%. I think the thing that we've found that has really driven utilization of our tool is really the practice facilitation and the ability for the facilitators for our health plan, not across our region yet, to be able to do an analysis on the practices individually before going into the practices, and then giving them, teaching them how to identify what areas of opportunity are best for them by going in through the tool and making them go in the tool and see where things are. And then taking that and picking out what is the trends across all of the platforms and working on those individual things. So it's when you give them, even if you give them 10 different dashboard items, if they're looking at three or four different payers, if you can get them to decide on one or two, then they're more apt to go in and use the tool and focus their priorities. But in absence of that, they don't have the staff or necessarily the analytic background to go in and find that themselves. So that's like really important for the practice facilitators to be able to have that capability and to help them understand where their opportunities are.
Yeah, I really like that concept of basically what you're saying is like customized use cases, doing your homework before you meet with the practices and then walking them through, you know, you are struggling with this measure and this is how to walk through the tool to figure out how to improve.
Yeah, unfortunately what we see, and it's because of obviously proprietary and HIPAA reasons, the practice facilitators of all the different health plans may only have access to their health plan if their health plan gives it to them at all. So it's really the responsibility of the practice to aggregate all of that once we help them identify their opportunities, which can be cumbersome in itself.
Right.
Thanks, everyone. I have a comment. Just I want to make sure that this gets stated while we're on the line. So in Oregon, this came from Emily Sykes, who's one of the conveners of the multi-payer group in Oregon. They have some practices who are huge fans of the Oregon's aggregated data tool, and they use it regularly. They're currently working on collecting specific use cases from those practices so they can share them more broadly with the other CPC Plus practices to help them see and understand the opportunities that will be presented with the tool. So you do have, you know, some experience on the ground, but again, it's early.
Yeah, that's great. Another thing that I've heard from a lot of practices is that they really just want a small subgroup of patients that they need to focus on. Like, we don't have the time or the effort to focus on 15 or 20 measures and or all of our patients. So, you know, who are the patients that we really need to prioritize our efforts on? So another thing that we're potentially thinking about for the future is incorporating some sort of predictive analytics. So rather than just who are my high utilizers as of 6 months ago, doing some predictive analytics to look at who are my patients that are at risk of hospitalization or escalating costs in the future. So I'd be curious to hear what others are doing around predictive analytics and if that has been helpful.
This is Diane Parrish again. Our tool specifically puts a risk score for emerging risk of the patients as far as risk of future ER visits, risk of future inpatient visits, et cetera, based upon analytics with diagnosis and their utilization and all of those things. The practices have given us a lot of feedback that is very helpful for them to identify which populations to go after.
Great. And do you look at individual risk scores for ED versus inpatient, or is it kind of one aggregate risk score?
There's an individual for each of our categories, plus there's an overall, and then we compare that to their HCC risk as well. So it can be a little bit confusing if you don't have a person who's dedicated to doing this kind of work yet in your practice, but for practices that do have some good quality programs, they really like to look at the different emerging risk scores of people so that they know that they may be someone they might need to reach out for their care management or their chronic case needs.
Sure. Yeah, that's a really good point about kind of the potential for confusion, because throughout this tool we are also displaying the HCC risk score as well as the risk tier. So we just have to be careful how we communicate it to practices.
I'm just looking at who's on the line and where the other regions that have done sort of aggregated work. Dick Shankar, are you still on the line? Maybe are you looking at predictive modeling at all based on the data that you've been collecting?
Not so much predictive modeling yet. We're still, what I really like about what the CMS tool does is the diagnosis specific data. We haven't, that's also on our drawing board to get into, because that really is what practices want to know, is they want to, rather than just looking at my whole population or even my individual patients. I've got a patient that, you know, is a high utilizer and, you know, has bad cardiac disease or whatever. Is that true for all my cardiac patients? And if it is, do I need to process improve somehow in the way in which to manage cardiac patients? So I think the tool that CMS has put together, we find really kind of complementary to the stuff that we take out to the practices in our data aggregation tool. Even though our tool does include the CMS data, we can get different views, if you will, from the CMS tool. So I really love the fact that this is being tried out in several different markets, and because I think by doing that and by having these calls, we all, you know, everybody's boat floats a little higher because we are kind of sharing some concepts and some best practices. So it, and shamelessly stealing from folks. So that would be the thing that I would, you know, that these calls are very worthwhile from my angle for that perspective.
Great, that's good to hear. Selfishly. Any other comments or questions? We're getting close to the end of the hour. I want to make sure that everybody has a chance to ask questions of Anita and her colleagues. Okay, well with that, we can give you a couple minutes back of your day. As I mentioned, this has been recorded. If you would like to have a chance to look at this again, we'll be able to post post this recording through our website, the Milbank Memorial Fund Multi-State Collaborative webpage. That will be up within the next couple of days. And certainly feel free to share with others in your region and communities. Thanks very much, and everybody have a good rest of your day, and thank you for participating. Anita, thank you so much for a wonderful presentation. I really appreciate it.
Thank you.
Thank you all so much.
Bye.